Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan. Now, here is your host, Joe Steckler.
I'm Joe Steckler, and welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plan. Our topic today is robotic surgery. Joining me today is Dr. Drexel Dobson with Surgical Associates of Brevard, Dr. Eldaif, Urology Associates of Brevard, Dr. Esemuede, Partners in Women's Health, and Dr. Guillermo, Sanabria, cardiac surgery. All are on staff at Wuesthoff Hospital, Rockledge, correct?
Correct, sir.
I thought that so many people are misled by everything they see on television, what they hear, and the amount of misinformation is so distressing to me at times, because I've been the recipient of many types of surgery. So I know the importance of the viewer understanding what it is that you're going to do when they start slicing. And I was very intrigued, Dr. Sanabria, about the field of robotic surgery. So if I wanted to get just a general answer on what is robotic surgery, would you, Dr. Eldaif, would you be the guy that?
Sure.
Who would? Okay, go ahead.
Well, robotic surgery is essentially a laparoscopic adaptation of surgery. So it's as opposed to the open technique, open surgery, it's utilizing scopes and instruments to operate inside the body.
I had the understanding that with robotic surgery, that there was a robotic or a robot arm that did a lot of the surgery, and I don't think I'm right. How does this work, Dr. Dobson?
Basically what it is imagine you have your cars, you have your Toyotas and then your Ferraris, etc. And the evolution of cars from a Model T to the 1940s to what we have today. So this is the most advanced version of a laparoscope that we can have. It gives us the ability to use 3D vision and allows us to control 3 arms. We're actually controlling the arms. The robot does not do the surgery. The surgeon does the surgery. We control these arms as if we were holding the arms. And what's the beauty about it is that these arms are infinitely precise, they're infinitely small, and allows us to be able to see better and to sew better and to do better and to dissect better. So it's the natural evolution of laparoscopic surgery, which at the beginning was just a simple telescopic camera with some simple instruments. This allows us to have wristed motion and allows us to do things real-time in 3-dimensional environment, such as all of us sitting here can look at each other and see we're sitting right next to each other. Everything previous to this was done simply like watching TV on a computer screen where you cannot appreciate depth. So everybody knows when they go to see a 3D movie that they can actually see depth and it feels like you're really there.
In my case, I had a dissecting ascending and descending aorta all the way down into my stomach, and I think what they did was they about an 8-inch incision in my chest, cracked my ribs open, went in and did the repair. And the doctor that did it, he used his hand. Can you do that type of surgery with robotically now?
Oh, if I may take that one. That type of surgery, which is a dissection, is not being done robotically. But there are many surgeries in the chest, namely the lungs, valve surgery, and now arrhythmia surgery, that we have the capability of doing with the robotics. And of course, this is just the new developments, but later on, that's a little bit more involved with respect to using the robotics. There are smaller incisions for that, but not robotically for dissection. A valve, yes, and for lung surgery, absolutely.
This robotic surgery, you can actually do this from a different location. You don't Dr., you know what I'm talking about.
Yes, and I think that's where we think the future of robotic surgery is going to go. And there are actually some cases out there where the surgeon is in a different state or in a different location and can operate on someone. These are going to have uses as we, even as far as the space station maybe one day, but even in far remote areas of the earth. Alaska, maybe areas where you don't have all the specialists. So in that sort of a case, a local surgeon can actually attach the robot, and then another surgeon, maybe in a different hospital, in a different state somewhere, can actually be linked to that robot and perform the surgery, providing that patient with the specialty care that they could not have gotten otherwise. But that's still in the future. There are a few cases of it, but that's definitely where we're heading, is that ability.
It was interesting to me when I started looking in my research to see what types of surgery could be done by robotics. I learned the answers sort of flip-flopped themselves. It became more interesting as to what could not be done. You're doing so much in the field of robotics. I think viewers would like to know what type patient, what type surgery is more conducive to having a robotic surgery performed on them. Whose area is that?
I'll start.
Dr. Eldaif.
I'll start because I feel that urology is one of the heavily. It's one of the areas that heavily utilizes the robot, and historically, actually, urologists pioneered the use of robots in pelvic surgery. So, as far as urologic cases are concerned, certainly with prostate cancer and kidney and bladder cancer, the robot has been invaluable in treating those type of diseases. It makes the surgical procedure shorter, more tolerable, perhaps even technically easier, and it gives the patient tremendous amount of benefits, such as less pain post-operatively, shorter hospital stays, and less blood loss. And so I feel over the last 10 years or so, in the area of urology, especially prostate cancer and renal cell cancer, the robot's been very well used.
I think prostate cancer was probably one of the first uses to which the robotic surgery was adapted. Is that correct?
Yes, it was, I believe, the platform for the robot. Like Dr. Dobson was saying, how the cars are every 10 years you're getting new models. I think urologists research and pelvic surgery, whether it's in urology or GYN, has helped the robotic manufacturers improve their models from one type to the next.
It was interesting when I saw the original cost of the equipment was around $1.6 million. And there was a lot of verbiage about how costly this was. And then I started doing a little mathematics, and I got to thinking, with all the savings in time which you have the person in the hospital, smaller cuts, less amount of pain, quicker recovery times, less hospitalization, I began to question whether or not it was so costly after all. I think it's probably very cost effective, isn't it?
It is. Actually, studies have shown that robotic surgeries, when adjusted to the appropriate surgery it's being used for, especially bigger surgeries, that the cost per procedure, although it's a little bit higher in the operating room, that the actual cost to the hospital goes down because you have improved outcomes, decreased patient stays, and decreased morbidities and mortalities, which is things that go wrong. One of the things that people say, and people who are naysayers to the robot, are people who don't have access to a robot and do studies to say why the old way is better. The old way is not bad, but it's certainly not better. And a lot of the problem revolves around availability of the robot. Now, the cost of the robot, people don't understand, or it needs to be clarified. The cost of the robot is like the cost of the operating room. It costs money to buy a piece of equipment or to outfit a room. That cost is not really passed on to the consumer. It's just the cost of acquiring a piece of equipment. There's some disposable costs that come along with every case. It's part of the robot that is not reused. Just like when we do regular laparoscopic surgery, there are things that we use in small cost things. But realistically, when you look at the cost, the $1.7 million is not big cost. When you look at the cost of an actual OR room to make is about $10 to $14 million to outfit and plumb and do all that stuff. So it's really not such a big deal, but people talk a lot because it is, for a unit of equipment, it's pricey, but it's the most advanced piece of equipment that we have. It's more advanced than the space shuttle was when the space shuttle was flying. So I think that's a reasonable price for something that's so complicated.
I heard the word, one of you mentioned the word gynecology, and that's your field, Doctor?
That is correct, yes.
How is, well, would the robotic surgery be used to treat female cancer? Is that what it would be then?
It's used for female cancer, but not just for that. It's also used for complex cases. So the robot really allows us to do cases that typically would have required a larger incision. You know, sometimes in a cross incision, like a C-section incision, but oftentimes a midline or up and down incision. And that can cause a lot of pain, can cause a lot of time in the house, and also can increase the risks later on of a hernia formation and, further morbidity to the patient. So it allows us to take cases that we normally would have done in an open approach with a large incision and do it with really small incisions, decreases the time. And, we're talking a lot about the financial costs to both the hospital and to the patient and to insurers, but also we need to think about the emotional and physical costs. When we see a patient and they come back at 2 weeks and they walk through a door, for their post-op check, and you cannot tell that they've had surgery just looking at them, versus the abdominal patient that's still crouched over and needs to be helped in, and it's going to need assistance at home for 6 to 8 weeks. That's a huge difference to that patient. These patients can go back to work much, much sooner, can resume their daily activities much sooner. So.
Okay. Say all four of your surgeons, correct?
Correct.
All right. Let's say you've got me on the table, and you use this robotic surgery, or you crack me open, get me opened up. What is the difference between getting the robotic arm control device? What's the difference between using that and your hands? I think in terms more like I was a plumber when I started out my original working career, and things, if they stayed in place, I knew how to thread a pipe and do things like that. But if things were moving, it became more difficult. How does that analogy apply to this type of robotic surgery?
And that's exactly the whole point. What's one of the most difficult problems of an assistant being a good assistant? Not moving. When the arms are placed into the body, and you have certain ports created, they're small, they're tight. Once you position them, you don't need an assistant. That's why the surgeon doing the procedure is at a console. You are able to retract, it doesn't move, and the exposure is so much better because of the magnification, the light. You have different scopes with different angles, and instead of just looking at something where you think a structure is beside that point, you can actually have a lens that'll let you see over the hill. So that's why visualization, the precision, and the exposure is something that at such a degree that I've seen some boundaries of tissues that I can't see with the naked eye. And granted, normally I operate with 2.5 magnification because of the surgery that I do, but this is that much better exposure. And again, now things don't move, things stay in position. So that's why I think we can do certain things. And one of the big advantages that I have to say, at least from the thoracic standpoint, is exposure to lymph nodes. And in lung cancer surgery, very important. It's been clearly shown the more lymph nodes you're able to remove, the better staging you can get and determine the patient's prognosis and be able to treat him correctly and not understage him. So I think it provides us with, besides easier and more controlled environments, more precision, less blood loss, more of a cosmesis issue. And remember, that's very important. I understand that it costs certain money to do something, but it's so important, and probably the more important thing is the patient outcome and how the patient feels afterward. If the patient's able to return back to activities earlier, not spend so much time in the hospital, not consume blood products, and narcotics are a big issue. Using too much narcotics is not a good thing. And if we can minimize that with the robotics, I think there's so many more advantages of using robotics than going the standard open procedure where everybody can see things.
I think that when I was doing my research, one of the things that I felt was probably more important to a surgeon was what you've talked about, is the magnification that you're able to bring about on what you're trying to fix. You can see it so much more clearly, and it gives you a different look at the problem. And it's kind of like the old saying, flying by the seat of your pants. You're not doing that anymore. But who would be an ideal candidate for this type of surgery, for robotic surgery? As surgeons, which type of patient do you think will benefit the most from this type of work that you're doing?
Well, all patients benefit. I don't think there's an ideal candidate. Certainly, people who may be thinner in certain procedures may have some advantages, but it also helps in patients who are overweight because it allows us to get to areas that would require a tremendous amount of force or pressure doing things laparoscopically. So we don't really have an ideal for it. Depending where you're operating on and what you're operating on, people who've had multiple operations can sometimes getting in to do the procedure in a minimally invasive fashion can be more challenging, and that's where the robot becomes key, because normally when you try to do something with a regular laparoscopic approach, sometimes you have to give up and do it the old-fashioned way. With a robot, a lot of times you can actually accomplish what you need to do because you can move adhesions and other things, especially in the abdomen where the three of us operate, out of the way, and then allow us to actually complete the primary procedure without having to open. So it really becomes, there are very few contraindications to people who shouldn't have robotic surgery.
What we've talked about, I think, so far what we've addressed mostly is the actual cutting out or replacement of tissue. But how about if, when you get into the area of bone replacement or knee resurfacing or hip replacements, can you do that with robotics?
You can do that with robotics using a robot made for that type of stuff, such as the Mako robot. It allows, that current device allows the knee, the joint that you're working on, to be positioned in a certain way, measured, and allows cuts to be more precise when replacing joints. But for the Da Vinci surgery itself, that is limited to non-bone type material.
Okay. But robotic surgery actually started in the early 80s. That's about when it started.
It actually started beforehand. The actual current model of the Da Vinci was a succession of robotic steps that was initially started by DARPA, which is the Defense Research Arm of the U.S. military. And the goal initially was to create a battlefield-type device that would allow remote surgery on wounded soldiers. And then the second application for it was for space travel, and the idea was to be able to provide medical services either to the space station or in long-range missions so that people could actually have surgery if they needed or if they were injured. That project then went to the private sector and morphed through different variations into what it is today.
So, you haven't talked a whole lot, Dr. Eldaif. What, in your field, what makes you more excited about the use of robotics?
I certainly feel that with the introduction and evolution of robotic surgery and urologic surgeries, especially for prostate cancer, the equation completely was flipped upside down. 10, 15 years ago, when you had prostate cancer and underwent surgery, it was a bloodbath, as we would call it. It's a very difficult area of the body. It's in the pelvis, very deeply seated in the pelvis. Lots of vessels and nerves, and lots of potential for injury and complications. The blood loss for your average open prostatectomy would be around 500 to 600 cc's of blood. And after the introduction of robotics, the blood loss is 50, 100 at the most. So very statistical significance in the reduction of complications and blood loss. And not only that, but I think the post-operative management of those patients has seen a radical change as well. Those patients, after prostate removal surgery, would be in the hospital for 3 to 4 days. They would wear a bladder catheter for 2 weeks. And with the introduction of robotics, those patients are in the hospital overnight. The catheter is out within 4 to 5 days. They're back to work within 2 to 4 weeks. So it's very exciting. It made a surgery that was viewed by the patient as a very tough thing to go through and recover from, as something that's more palatable. And that's reflected in the amount of robotic prostatectomy cases that are done now in the United States. There's more robotic prostate surgeries that are done versus the open approach, the traditional open approach.
One field of medicine that I think gets under-talked about a whole lot is female care. I did one show with Debbie Whitnall, who is your nurse in your women's heart center. She's an extremely knowledgeable lady. I thoroughly enjoyed doing the show. Mm-hmm. But the word prostate cancer has come up an awful lot. Mm-hmm. But as a doctor and as a woman doctor, what makes you more excited about the use of robotics in your field?
It's really the patient outcomes. They do so much better. We use the robot now for cases as far-reaching as removing fibroids, which could cause pain and bleeding. We do it for endometriosis cases where we need to separate tissue, remove endometriosis implants, and that can help with pain as well. And those are quite difficult surgeries. We often work with the urologists and colorectal surgeons on those cases. And then, of course, hysterectomies are one of the most common major procedures done in the United States. And hysterectomies are done for a variety of reasons. For prolapse, the uterus falling into the vagina, for fibroids, for pain, for bleeding. And each of these have different indications, but in terms of the fibroids, some of these are quite large, and those often require larger surgeries. And now we're able to offer our patients, instead of an incision stretching, from their belly button, all the way down, 2 to 3 incisions that are less than a centimeter each. And the other thing that we have not addressed here is really with the robot. The one thing that I really love, besides the magnification, is that third arm. When we're operating in an open case, I have 2 arms, and I have another assistant come in and help, and I have to instruct them on how to assist. With the robot, I can actually, it's almost as though I have a third arm. I can actually use an arm to retract for myself. I have that control. I don't have to explain to someone exactly where it is. I can move the camera, and at the same time I can operate. And that gives us, and also it takes away any tremor. So if you have any caffeine tremor, that helps as well. Yeah. So.
Well, let's say, and we get an area, this is going way too fast. Just the half-hour show is not much at all. But in this field of breast cancer, if I'm thinking of a case where I know a lady that had, I think it was the cancer in the left breast, but she had the cancer traveled all the way around to her back and before they discovered it. Are you able to use of robotics to do a better job of locating cancers that moves through the body?
Well, I think the robot is really good at identifying. One of the ways that cancer moves through the body is through these structures called lymph nodes. And the robot is very good at helping us identify structure because of the magnification. It helps us see better, it helps us dissect better, and it helps us pick up a lot more of those lymph nodes so that we can stage cancer more appropriately. So definitely the robot does improve the lifespan of that patient by improving the quality of that initial surgery.
I guess the concern I had, and the reason I asked the question about raising awareness in women of what's available, because we think mostly of prostate cancer, other cancers, and we generally think about men having surgery. We don't think that much about women being susceptible to the same thing. And more has come out now about women having problems with heart disease, and that's something that was sort of played down before. Mm-hmm. But these 3 would be more classified as a specialized surgeon. You're more of a general surgeon. Am I wrong?
I'm subspecialized too.
You're specialized too? Okay. But what, are you still you're the chief of the medical staff?
Not anymore.
Now you are. Okay, when you were chief of the medical staff, what made you excited about the field of robotic surgery being available here at Wuesthoff?
Well, remember, again, besides being, as all of us being surgeons in specific fields, if we can do the surgery more precise, see things we couldn't see before. Again, like the doctor stated, the issue about lymph node and staging is crucially important. We could talk about that for another couple of hours, each one of us. So if we can provide the better care for the patient feels better. And this is a service that if you can stay less time in the hospital and get out of here faster and feel better and return back to work. Remember that being out of work is a costly thing throughout the country.
Yes.
If that's what excites me, that if we can provide the patient with better outcomes and they can recover quicker, I think that's the thing that excites me the most. Is there a learning curve in robotic surgery? Of course there is, like anything that's new. And by learning curve, I mean you're going from something different to you and you're going to another field. But my prediction is eventually with time, this is going to become more of the norm than the exception. And other fields we have not even mentioned here, besides our friends in orthopedics doing their knees, ear, nose, and throat doctors. As you know, nowadays, when the robot gets involved in their field, they're able to do dissection, get to areas without deforming the faces the way they've done before.
Okay, we got a minute left. What haven't I touched on that any one of the four of you would like to say in about 35 seconds?
Well, I think that
Okay.
the easiest way to sum it up is that the robot is the next step in what we call the standard evolution of technology and surgical care. It allows us to do the most accurate surgery we can possibly do. It allows us to do more complex surgery that we've done before. It allows us to do it better. It allows the patient to recover quicker and have a better outcome. So really, when we talk about being cutting edge, this is really what that is.
Yeah. I think the one thing that the last comment I would make was that everything all four of you have said, the robotic surgery itself causes less of an invasive procedure into the body, which reduces the amount of muscle and everything that you have to cut through, and that causes less blood loss, less pain, quicker recovery and everything. So it's how we treat ourselves. I want to thank all four of you for being here. This was much too quick. I want to thank you for watching today's episode of Focus on Seniors. If you have questions or comments, please call us at area code 321-473-7770. For more information on senior care and resources, visit our website at helpingseniors.brevard.com. Be sure to listen to Focus on Seniors on radio station WMEL AM 1300 every Thursday morning at 9 a.m. and also look for our Florida Today newspaper session. In the health section, our column is Focus on Seniors. I'm Joe Steckler, and thank you for joining us today for Focus on Seniors. And thank all four of you. I really appreciate it.